Welcome to another episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor.
Welcome everybody again to another episode of our show. Today we're bringing a really awesome guest involved in science, technology, medicine, creating a better tomorrow for many patients out there. Today we're joined on the show by Dr. Reynold Panettieri, who is the inaugural director of the Institute for Translational Medicine and Science and Vice Chancellor for Translational Medicine and Science at Rutgers University. Go Scarlet Knights. Previously, Dr. Panettieri served as both the director of the Airways Biology Initiative as well as Deputy Director of the Center of Excellence in Environmental Toxicology around the corner here at Penn. And he has rather broad interests that include the cellular and molecular mechanisms that regulate airway smooth muscle cell growth, the immunobiology of airway smooth muscle, as well as studying various interesting dynamics of signaling pathways and gene expression, all, looking at this, future of potential disease modification in the asthma and other diseases of airway biology space. In addition to his research and clinical interest, he served as a chairperson of the NIH Lung Cellular, Molecular, and Immunobiology Study Section, and is a member of the NIH Distinguished Editorial Panel, and a member of the American Society for Clinical Investigation and Association of American Physicians. Did his medical degree, residency, and fellowship all around the corner here at Penn Hospital at the University of Pennsylvania. And honored to have him with us. A lot to get into today. Dr. Reynold Panettieri, thank you so much for taking the time to come on the show.
Well, it's my pleasure. Thank you for that wonderful introduction. And it's a thrill to be here. I'm very passionate about what I do and looking for new therapeutics or biomarkers to characterize asthma, the diagnosis and management thereof. And there's really new therapies that have become available, which is exciting. It has really transformed our ability to manage this disease.
Yeah, absolutely. And it's interesting. You have an extremely impressive dossier of somewhere like 400 publications currently. And looking back at some of them from the 1980s, I mean, the themes again of immunobiology, airway remodeling, environmental health, and then therapeutics. It was all the themes in the 80s as well as now. And I'd just love to hear a little bit of the background of what got you started fast and furious into sort of respiratory health in general.
Yeah, so as a pulmonologist, practicing pulmonologist and a physician scientist, what turned me on in pulmonary was the broad sense of pharmacology and physiology of the lungs. The lungs are fascinating, right? Can't live without them. They exchange gas, and they are also very active as metabolic organs. But when they go awry, and especially the tubes or the bronchi, when they become hyper-responsive or hyperactive, then that induces wheezing, chest tightness, and cough. The other important aspect for me when I was starting out and examining this is how profoundly it affects Americans and people globally. 1 in 20 of the US population has asthma. If you go to the cities and city and urban dwellers, it's almost as frequent as 1 in 12. 1 in 12 have asthma. Asthma can occur anytime in life. It can occur as a child or as an infant, and then even in your 80s and 90s, you develop asthma. So why was I interested in pulmonary? Fascinating organ. The pharmacology and physiology I found thrilling. But then the application of that skill set and toolbox to a disease that affects so many people's quality of life and functional status excited me. And so I could blend my interest in science pharmacology with that of chronic illness. And it was history after that.
Hmm. Hmm. And it's interesting because you talk about, I mean, there's staggering numbers nowadays when you look even at sort of the broader of sort of the diseases of airway biology. And obviously people listening and watching will be familiar with asthma and say probably COPD next after that, but dozens of other conditions. My mother had bronchiectasis later in life. We hear a lot about IPF and sort of these interstitial lung diseases and the whole rare disease space too. I mean, dozens of rare diseases popping up that we're learning about have some pulmonary involvement. Talk about the broader landscape, if you would. Because I mean, we're talking about almost half a billion people worldwide now with something in this category. And I was wondering if you could just talk broader, and then we'll get to asthma afterwards about
Yeah.
the broader areas.
Well, you're absolutely correct. Lung diseases in general affect an enormous amount of individuals, and many of those orphan diseases you described, some like cystic fibrosis or idiopathic pulmonary fibrosis, these are chronic illnesses that had profound mortality, still have morbidity, but we have made incredible strides. So the fact is that we don't really know the cause of many of these diseases. The pathogenesis remains unclear. And what we do is we manage the disease, a disease that we don't understand why the patient, one individual gets it, another doesn't get it.
Mm-hmm.
And that makes it really difficult. If we knew the causes of these, then maybe we could eliminate some of the susceptibility or the capability of developing the disease. So, I think at the end of the day here, lung diseases continue to increase.
Mm-hmm.
For example, if you take COPD, not many people realize that if you've been hospitalized with COPD, hospitalized with a flare of your COPD, your life expectancy at 5 years is 50%.
Mm.
Do you realize, Ira, that's as bad as lung cancer?
Yeah.
And the reason is not only the lung disease is a killer, but it's all-cause mortality.
Yeah.
So when the lungs go bad, the heart's affected, and obesity sets in, and there's a variety in the snowball then it goes and goes, and it gets larger and larger. So the concept here is that lung disease have myriad effects on other organs that cause those organs to fail. So it's a domino effect. But we need more research. We need new therapies. We need new therapies specifically in IPF or idiopathic pulmonary fibrosis. Yes, we have a couple approved drugs, but I would say that it's less than optimal in its management and decreasing death rates. COPD, new biologics have occurred. It's going to be transformative in that space as biologics were, if I look at that in asthma. So I think we're excited about this whole class of drugs, biologics, monoclonal antibodies that are going to affect orphan diseases and so forth.
Mm-hmm. And in your practice, just wondering when we drill down to asthma, because your literature is full of everything from genetics to epigenetics to the exposome, which we'll be talking about in a bit, to the allergen component of this. I mean, over the last few decades, have you seen sort of the etiology, the focus shift? I mean, what has sort of been the pattern there? And so I know we still still kind of a black box, but where are the bets being placed, let's say, in terms of sort of those underlying causes nowadays in 2025 versus what we thought a couple
Yeah,
decades
so
ago?
so so what we've recognized before that many of the diseases are heritable, right? So uh, you know, people in your immediate family have similar diseases. And so somehow there's a genotype or a genetic predisposition to the development of the disease. And we're getting more refined in the characterization of susceptibility. So there is epigenetic effects where the environment could actually impact on your gene makeup that then actually gets inherited in your children. So that was completely unknown before. So the epigenetic component is clearly there. Pollution, which was so rampant in the 60s and 70s, have improved, but surprisingly, some of the pollutants have changed. We read about microplastics now. We see the Canadian wildfires as having profound effects in patients with underlying lung disease. So, the pollutants and the exposures change with time. We've also realized the magnificent effects of vaccinations on outcomes. We didn't have these drugs before. And then, as I mentioned, the new biologics, which are now much more effective in decreasing adverse effects to medications, but also improving outcomes.
Mm-hmm. So, moving along that line, so we have, a lot of classes, as you're pointing out, in terms of long-term asthma control. So you mentioned the biologics, we have leukotriene drugs, oral steroids and all that. But at the end of the day, as you mentioned, we need our lungs to live, we need to breathe, and there's always going to be that a need for the quick relief, short-term relief of symptoms. And again, I was trained around the corner from you as a pharmacist originally, and dispensed many, bronchodilators and steroid inhalers, going back to the 1980s. Talk a little bit about sort of the dynamic, because we're going to be getting into sort of a major change based on what you've been learning recently in the super study and all that. But talk a little bit about what the standard has been in terms of the quick relief rescue needs for these patients, because it's obviously very important. They need to breathe. What have the things been the last couple of decades? What's the pattern been?
So let me step back and phrase my answer a little differently, because a lot of my colleagues that are listening to this, or patients who are listening to this podcast, don't recognize when we give a patient a diagnosis, it's not a simple diagnosis: asthma, COPD. With embedded in those diagnoses are subtypes of the disease.
Okay.
And those subtypes of the disease are called heterogeneity of the disease. So all diseases are heterogeneous. They're not one disease. So you may say, well, Panettieri, why do we need all these drugs? Well, that's because there's a heterogeneity of the disease process that doesn't predict therapeutic response to any one drug. So you need multiple drugs. Now, the trick, though, is to try to pick the right drug for the right patient at the right time. And that way we're not guessing that, well, let's try this and let's try that and let's try that. So the heterogeneity of the disease is one aspect, but everyone who takes any medicine, because of our genetic makeup, have a heterogeneity of response to therapy. That is, if I give you a pill like prednisone, you may not have any side effects, but the patient next to you who gets prednisone develops cataracts, glaucoma, or bone loss. That's a heterogeneity of our own genes in response to the therapy. So collide these two together: heterogeneity of the disease and heterogeneity of response to therapy. And it's a miracle that we get any drug to work in any patient. So the whole point here is, going back to asthma, you had rescue inhalers and you had maintenance inhalers.
Okay.
Maintenance inhalers, you need to take every day, day in and day out, usually an inhaler. That was a combination of a long-acting beta agonist or bronchodilator, as well as an anti-inflammatory. What we have learned in airways disease, not only asthma, but COPD, is that inflammation is a cornerstone in the pathogenesis of the disease. So if you use a bronchodilator, that relaxes the muscle. It could also change the vasculature and permeability, but it doesn't act as an anti-inflammatory. And if I said that the disease is characterized by smooth muscle shortening, contraction, and inflammation, using a rescue only saves the one side, not the other side. So you have to use combined drugs. Most maintenance inhalers have 2 or 3 drugs that are available to the patient. That's because 1 + 1 + 3, 2 = 5. All of them work synergistically, and that's why combination therapy is important. Now, for rescue, the one that we most commonly use is albuterol. It's used to relax the muscle. With relaxation of the muscle, you get swift relief within minutes of chest tightness, cough, and wheeze. So somebody who's allergic, for example, to a cat, gets exposed to the cat dander, gets tight, starts coughing, they can use a rescue inhaler and get a relief within 5 to 10 minutes. But you're only relieving the smooth muscle shortening and contraction. You're doing nothing for the inflammation. You're relying and leaning on that combination therapy that you take every day as maintenance to cover you. Unfortunately, depending on the trigger, depending on the cause of the exacerbation, you may have more inflammation or viral infections that's not easily managed by the continuous use of the therapy. So the maintenance can protect, but often can't protect you against every instance of a trigger.
Mm-hmm. So that being said, I appreciate you outlining the sort of the combinatorial nature of what you're looking for here, but specifically in terms of rescue. So we have a product there, Supra, that combines albuterol, as you were mentioning, with budesonide, so combining the quick relief with the anti-inflammatory action, and the Batura study, which was a phase 3B study, which just completed, and people listening can go to the New England Journal of Medicine in July of 2025, as needed albuterol budesonide in mild asthma. But nonetheless, the results here in this phase 3 were pretty staggering in terms of significant reduction in severe exacerbation and an early stop of the study just because it was doing so well compared to what the standard has been for decades now. Take a little time and walk us through the study and a little bit of what you saw when you opened this data.
Yeah, so I'm going to use a term that I like to use when I'm really excited about a drug, a study. This study was drop dead gorgeous. And it was drop dead gorgeous for two reasons. One, it built on a previous New England Journal of Medicine article published about 2.5, 3 years ago, where we looked at Air Supra's value in moderate to severe asthma as rescue. What that study, the predecessor study, showed is that using that rescue, an anti-inflammatory and a short-acting beta agonist together for rescue, spared exacerbations in the moderate to severe asthmatics who were on standard of care. They were receiving maintenance therapy already. So this was the first ever, I'm talking about the study several years ago, first ever study to show a rescue inhaler could spare exacerbations. Why? Well, because you're on demand using more anti-inflammatories for triggers that are typically causing inflammation. So it made sense. What did Batura offer different than the other 2 years ago study? Well, Batura took the notion to intermittent and mild asthmatics who may not have even been on standard of care maintenance therapy and used it in those individuals, and lo and behold showed that they had even more effect of the rescue inhaler on exacerbations. So what we did is extended that previous study that were in moderate to severe asthma, always on maintenance, to those patients who may have gotten low dose maintenance therapy or no maintenance therapy, and showed that you could spare exacerbations. The other important aspect of Batura, really fascinating study, is it was done completely decentralized, meaning the entire study, national study, thousands of patients, never saw a provider or a clinical coordinator. It was all done in their home using electronic monitoring where placebo drugs and the Air Supra was sent to the home in a randomized controlled manner, and the entire study was conducted in patients' homes without ever going to a clinical research unit. Why is that important? Well, this shows the feasibility of doing placebo-controlled trials nationally that will allow patients to get into studies that need not take time off of work or travel to a clinical research unit or do all the other things that are disruptive to their quality of life and time. So bottom line here, Air Supra was very effective in sparing exacerbations in intermittent and mild asthmatics who may or may not been on maintenance therapy. It validated, confirmed, and extended the observations of the previous study in the New England Journal of Medicine. And we've demonstrated for the first time the capability of doing a randomized placebo-controlled trial in patients' homes without ever having to see the patient face to face.
That's beautiful. That's beautiful. Are you seeing? I mean, just thinking beyond, because I know you oversee the entire Institute of Translational Medicine there. Are you seeing a lot more of sort of this trans? I mean, we talked a little bit about distributed clinical trials and on the show, but what's the general sort of movement there at the institute in terms of wow, hey, we can do this. Well, can we do X, Y, and Z as well?
Yeah, we actually we cut our teeth on the first study during COVID,
Mm,
where we adjusted the microbiome to generate anti-inflammatory effects by modulating the microbiome, and we did that in a decentralized manner, where people would get packets, would change the flora and fauna of their gut and look for the response to COVID infection. That is, how long they had it or whether it could spare the severity of the disease. But we really understood at that point the wonderful opportunity to do decentralized distributed clinical trials. Matter of fact, the greatest number of participants were not in New Jersey. They weren't in our area. They were
mm,
actually in Texas and Minnesota.
wow.
And so who would have guessed?
Yeah.
But those individuals would never even heard of this clinical trial, which was investigator initiated. So the point, Ira, is that in our armamentarium for doing high quality clinical trials that get published in journals as impactful as the New England Journal of Medicine, we can do
Yep.
decentralized studies. And I see this being a great benefit to patients who otherwise are cut out of clinical trials because they can't afford the time or effort to go to CRUs or clinical research units.
Excellent. Excellent. That's a lovely, in terms of the Batura statement, it's a lovely example as you were pointing out about, a game-changing study, distributed combination therapy. I'd like to, sort of look at the other end of sort of your pipeline there at the Institute, because one other very interesting thing that stood out to me was your work sort of in the ex vivo model space and these really interesting precision lung slice technologies that you're developing. And again, looking at, beyond the sort of the traditional in vitro model of, we want to hit these cells over here. But when you look at some of these diseases, we're talking about fibrosis, injury, different repair and defense mechanisms, a lot going on in the lungs. With these interesting models that you're developing there, you can kind of look broadly again and not study maybe one drug, but multiple drugs, look at different parts of the pathogenesis. Talk a little bit of what you're doing there, because I think it's another important part of sort of the pipeline that you're developing there at the
Yeah.
Institute.
So I think one of the large unmet needs in development of new drugs and targets and therapeutic targets is to use human cells, human tissue, and human platforms. And the reason is that many of the rodent models that have been established in lung disease, they somewhat mimic and mirror human disease, but they're not the same. There's dramatic interspecies variation. So yes, it's a living, breathing, maybe rodent mouse that you do the study on, and that's great for pharmacokinetics and pharmacodynamics and bioavailability of a drug in a whole organism. But the interspecies variation means the interpretation and translation of those findings directly to human disease is not equal and
Yeah.
it's not the same. And often what we show in the animal models with brilliant success fails miserably when you go to the heterogeneity of humans. Remember, mice are inbred. They're all
Yeah.
the same. Well, humans aren't, right? So we have a heterogeneity that renders the observations that we find in rodents ineffectual when we go to broad populations of humans. So what we developed are models of human models of integrated tissue models where we take a whole lung, we inflate it with low melting point agar, we section it and slice it so we can keep a human lung slice alive for 2 weeks. The cilia beat, the mucus glands secrete, and the muscle contracts and relaxes. We get about 500 to 600 slices per lung. We get every 2 weeks a lung. These are aborted lung transplants. So we use that as a platform to study the intricacies of target validation and efficacy of drugs in the human model with all the cells in register in situ. Now, the one thing we don't have, obviously, is trafficking leukocytes because we have no circulation. We have a slice in a petri dish. But guess what? That's actually a benefit, because if we can show that the structural cells there have an outcome that is favorable, then that's very useful, because we're directly addressing structural cell function, which is usually inaccessible if we're doing a whole human study. What can we do in whole human studies? Well, collect exhaled condensate or breath, or do blood tests. But I can't take the muscle out of a human necessarily and study it and determine whether it's a direct bronchorelaxant or contracting agent. But the point is, we want to get away from rodent models that may not be predictive. We want the ability to translate discoveries right to patients so we can move swifter. And I think the organoid models that are integrated cellular models, or the precision cut lung slice model, offers that opportunity. And the numbers of cells and tissues that we have can be used for moderate throughput screening of new drugs.
And again, along those lines, as exciting as the Batura Air Supra New England Journal of Medicine paper is, there's another very interesting paper that you published 1 week before that, and I just want to bring that up while we have you today. It's in the Journal of Allergy and Clinical Immunology. It's entitled "Disease Modification in Severe Asthma: Are We There Yet?" And terms in this paper include remodeling, reversibility, remission, cure. I love those terms. And you talk about combinatorial approaches, novel screening methods, heterogeneity of disease. I don't know if we're there yet. I'll ask you, are we there yet? And where are we going? Take us out a couple of years, if you would, because clearly you've talked about many of the pieces that need to be put together for us to start talking about words like that. But
yeah,
love to get your perspective looking out a bit now.
Yeah, so sometimes we reinvent terms, because if we go back about 10 years ago, Dr. Bateman had put forward complete control of asthma. And he was a New Zealander who came up with this notion. And it carried forward that we rarely can get complete control of asthma. I'm using asthma as the paradigm here. And what does that mean? That means patient has zero symptoms, no exacerbation, and is on a stable drug for a long period of time. But we realize that even in the best of hands, the most knowledgeable experts with the current therapy, we could only achieve complete control in about 15 to 20% of patients, meaning 80% of patients couldn't be controlled. As we develop new therapies, and this was well before the 6 biologics that we now have in the asthma space, we've realized that some patients actually do get much better control. Dr. Bateman didn't have all these biologics back then, so we had new therapeutics. So then came the concept of remission. And what remission means, it shouldn't be used in the context of cancer, where you have a cancer remission. They talk about remission, you're not cured, but the disease is quiescent and stable, versus cure. There'll never be a cure of asthma, I think, in my lifetime. But there can be remission with these new therapeutics and biologics, because what we can do is eliminate the attributes of the disease, chest tightness, cough, and wheeze, have people maintain on a biologic with minimal standard of care inhaler therapy that doesn't have to go up or down, and not use rescue therapy. So that's how we define remission. I think we are, in some individuals, at that stage where we can use the term asthma remission. What percentage? Well, I talked about that 15 to 20% before. I think with biologics, we're probably at about 40%. Pretty amazing in some individuals. There's other individuals who get on a variety of biologics and are still not controlled. So we don't have the solution for everyone. But I can say we're moving and inching our way to total control or remission, not cure. And that's very, very exciting.
Mm-hmm. And while we have you, I just have, because I mentioned obviously your the major role that you played previously around the corner here at the Center for Excellence in Environmental Toxicology. This principle of the exposome has it's more prevalent than I remember in the past. And before we got on this call, I read we currently have something like 350,000 documented chemicals and 40,000 or so of those show up in human blood. I know the exposome is still a part of your program now at Rutgers, and just love to hear sort of what direction you're going there, and then any interesting learnings, insights during the COVID period when everyone was wearing masks, and how that impacted what you were.
You know what? COVID was incredibly humbling as an asthma and COPD doc. It was humbling, not because of the severity of disease and the mortality associated with that. That was a disaster, no doubt about it. But what we learned is wearing masks and social isolation had a profound effect on exacerbations of both asthma and COPD. In other words, we saw dramatic decreases, and we published work on this, dramatic decreases in exacerbation rates in asthma and in COPD. Well, you say, well, you had a virus that was killing people. How could that be? Well, what we did in COVID, as you mentioned, Iris, you wore masks, you socially isolated, you distance yourself 6 feet. So what we had is less person-to-person contact that transmitted viruses, bacteria, or toxins like cat dander. Most people have cat dander on their clothes and they don't even own a cat because it just flies from person to person and it's on your clothing. So the whole point here is what COVID taught us is that many of the triggers that cause an exacerbation are inhaled. And by eliminating contact, you have a profound effect on asthma exacerbations. Now, the exposome that you mentioned, I mean, I think what we were very sensitive to 30 years ago or 20 years ago is one molecule causing a problem, like ozone, for example, or sulfur dioxide. These are common pollutants that you see in hot summer's day in the sun, and they can affect asthma exacerbations, no doubt about it. But where that science is moving is to complex mixtures. You can study one molecule and be a purist and a reductionist, but in essence, people are inhaling not only ozone, but sulfur dioxide and other things. So the science of the exposome is now moving not to single challenges or molecules, but to combinations of that. And let me use a perfect example. We're studying Canadian wildfire. On the East Coast, as you know, we have a beautiful orange haze as a gift from our Canadian colleagues. And it actually makes the sky look milky. And you can actually smell wood burning in the atmosphere. Well, that's a very complex mixture of a variety of residual particles, particulate matter, as well as other molecules from the wood burning that then induce asthma exacerbations. I've seen a big flux in my own practice recently because of the Canadian wildfire pollution. People are having exacerbations. So the studies now that we're conducting, and you'll find interesting, is we're collecting the Canadian wildfire smoke and adding it to our human precision cut lung slices to understand how complex mixtures of toxicants can affect lung function. We also compared that to the UCLA fires. Now, the UCLA fires were vastly different because think about it. They were burning houses. There was plastics. There was all kinds of other toxins that don't exist in forests. So the LA fires, and we collected that gas, had a markedly different effect in our models than the Canadian wildfires, both of which were detrimental, but in different ways. So what's the take home on the exposome? It's not one molecule, it's multiple molecules combined. And it's that combination that is where people are now putting a lot of their time, effort, and resources in the characterization of the consequences on lung disease.
Got it. Really cool. Really cool work. Dr. Panettieri, what should we be on the lookout for in terms of you for the rest of the year? I see that there's an international asthma conference down the turnpike in Nemacolin, which sounds like a great place to have
It's
an
a
asthma
wonderful
conference.
place. Yep.
Yeah.
The
What
American
else is happening?
The American Thoracic Society chest meetings are going to be coming up. The chest meeting is in the American Thoracic Society in 2026. Big meeting, one of the largest scientific lung meetings in the world. That'll be held in Orlando. CHEST is another great clinical and scientific meeting with more focus on clinical outcomes. That'll be in Chicago in the fall. So there's numerous opportunities. Nemacolin is an asthma meeting devoted to an international asthma meeting. Wonderful, more boutique meeting. The Eastern Pulmonary Conference is held in the Breakers in West Palm
Ah,
Beach.
nice.
An awful place to go. Uh, so, there's a number of great places you can learn a lot. And I think that's what's on the horizon for educational opportunities.
Awesome. Awesome. We will put all these links in the bio notes of the show so folks can find you and keep an eye on everything that's happening. But really, extremely impressive set of work. And I really enjoyed talking to you about the past, present, and future of where this is all headed. Again, for everybody that is going to be listening to this episode across the various podcast networks or who will be watching on the YouTube channel, you've been spending time with Dr. Reynold Panettieri, Inaugural Director, Institute for Translational Medicine and Science, Vice Chancellor for Translational Medicine and Science at Rutgers University, doing really amazing work to move forward the discovery, development of these novel therapeutic interventions for diseases of the airway. Dr. Panettieri, I really want to thank you for taking the time to walk us through all these topics, everything you're doing. Thank you for what you do for all these patients. And as we like to say on our show, thanks for helping to create a better tomorrow for literally millions, tens of millions of patients out there. Really an awesome story, and I look forward to continue to follow you.
Great. Thank you, Ira, very much. Have a good day.
Great having you.